So this is about 2 hours post-intubation on APRV. So the volumes were like around 220 initially when we were trying ACPC with a pressure control of 30. We switched over to 300 tidal volume, and that was an ACVC. We had plateaus around 33 with only 300 tidal volume. The electrical impedance tomography that we'll look at, we have evidence that the lung was actually quite de-recruited because of the impressive response to intubation and positive pressure ventilation. So this was 200, so 220. So we're like a good 150 cc's 2 hours post intubation with APRV with a T high of 3. We're going to look at here the electrical impedance tomography by Draeger. There's a reference down here, and there's the control. Okay, if we connect the ventilator with this cable to the PulmoVista, we'll also have the settings. Sometimes they're a little bit off. The P high has been 30 the whole time, so there you can see that there's a little bit of discrepancies, but as long as you know which parameters are on, it still gives you a good idea of where you are in your changes in accordance to the lung impedance. So there's a few ways of looking at this screen. If you're trending upwards in your ventral, mid-dorsal, and dorsal regions, it means that you're recruiting. Impedance is synonymous with volume. So if you have an increased impedance in a certain area, it means that volume has been redistributed to that area. And if you have a loss in impedance, then it means that compared to your reference, there's less distribution of tidal volume going to that area. So we're always comparing. The trends are a nice way of quickly seeing if we're recruiting and in what regions. We also have the change in electrical and expiratory lung impedance over here. So if you start seeing this being positive, it means you're gaining impedance compared to your reference, and if you see negative, it means that you're losing impedance. Now, before I start moving the scroller to show you what's happening in this individual's lungs, just remind you: 1, 2, 3, 4. Ventral, mid-dorsal, and dorsal. This is the chest, and this would be the spine. Okay. One moment. I'm just going to press pause for a sec. Okay. Over here you see orange, and over here you see blue. Blue is gain, orange is loss. Orange does not necessarily mean that it is bad. If we are doing changes and we are getting orange here, a loss in your ventral areas, and it's being redistributed and showing up as blue over here, this orange wouldn't be bad. Okay. Now, if you're making changes and all you're seeing is, let's say, blue being increased here, that doesn't necessarily mean that's good either. It could mean that you're increasing your pressure control, and you're just pushing everything to the ventral areas. So it's not necessarily bad to be orange, not necessarily good to be blue. I'm going to start here by pressing my control, and you'll see here as we scroll across, it's measuring the differences. So let's look at this first. Okay, so this is 1240 to 1440. Okay, so this is staying with the same P high at 30 and the same T high now for the last two hours over 3. So here you see that volume is being redistributed to the ventral area. Now, this is not bad for this specific patient, because when I show you the main screen, he actually has most of his ventilation here, and here there's very little. So by adding positive pressure ventilation, you're getting better maintenance of the lung here, staying open. 1 second. Sorry about that. Yeah, so we're getting blue up here, but you know what? Here it's 11%, which is 8 to 15 is normal. So the patient's perfectly recruited here. There's nothing else that can happen but to inflate this deflated area. Okay. So I'm going to continue scrolling. Sorry for the shakiness. Okay, again, so now you're starting to see here a loss in your mid-dorsal region, a redistribution up to the area that had no volume initially, but we're also starting to get this dorsal area here that's getting more distribution, which is the gravity-dependent regions. Let's continue scrolling over time. Press my control. Okay, so now we see, let's see over here, this is over time. I'm going to try and scroll a bit like this. Okay, we'll go quickly because I just wanted to show you the picture. Now it looks like the picture is not moving if I'm scrolling this way, see? Not much change has occurred, at least in the visual aspect. So this is where you can see quickly the trend. You can see here your regional distribution of ventilation, where you've lost, where you've gained, and then after you have the the change in electrical impedance in the end expiratory lung impedance. So let's start over here, and then let's start scrolling. Okay, concentrating on this. So globally, somewhere, it's not saying which region, but it's saying overall there's 0.5 increase in impedance. And we can see that initially this is only occurring in a region of interest 2, which is mid-ventral. There's a little bit of gain here, nothing substantial. Now, we have to keep in mind that when we started all of this, the dorsal region, which is 8 to 15% of the volume should be distributed there, it was already 8, and then it increased actually to 11%. So I'm not expecting much more drastic increases in impedance here, but I am expecting actually some increases more over here, because that's where there was really no substantial amount of volume happening. Now I understand the gravity dependent regions are the most important, but we're still losing a lot of diffusion capacity. It's not like the top of this lung here is completely useless. It does take part in gas exchange. All right, so now we see, so this is roughly from 244 to 114. We're seeing continually increasing impedance over time. And we're starting to see a substantial amount here. We're starting to see a substantial amount here, which is okay. Again, I keep on repeating it. There was no distribution almost there. So we do want a more well-distributed area distribution of ventilation. Let's continue. And it just keeps on going, going and going and going, going and going. And we can see here that there is slowly starting to gain. It's not as obvious on the trend here, okay? And let's just go to the end now, okay? So this was 8.29, and this is going from 1244 to, from 1244 to 244. What I'll do is I'll pop up at the end of the video just the other screens, because I have right here you can go for 120 minutes to trend it. So this only captures at 1244, but he was intubated at 11:35. So there's a whole hour of this kind of information that is no longer accessible. But as it was happening, I was exporting screenshots. So I'm going to print those out, and I'll be able to add a little bit to this video. And let's just do the main screen. This is what I was telling you. Notice here, 4 and 3, okay, are good, okay. And let me just pause it because I'm shaking. Okay, sorry about that. Okay, so if you look over here, I referenced this. This I think was about an hour, but initially it was 8%. So we did increase here at this region, but look it up here. This is supposed to be 8 to 15% in the ventral area, and this is supposed to be 35 to 40. So we see that a lot of the aeration is in the mid-dorsal region. This is good, But there's nothing wrong with having this number, so this is good, but there's nothing wrong with having this number at the mid-dorsal region starting to be redistributed up here to have a more homogeneous distribution of ventilation. So that's why we were seeing previously on the end expiratory lung impedance a lot of gain in this region. This is not indicative of hyperinflation, which could occur. The blue up there could occur if you're hyperinflating. But in this case, we have the history, we have previous tomographies, and we know that for some reason, it's actually the ventral areas that seem to not be getting much ventilation when we're, usually it's a dorsal issue. Okay, so that's pretty much it. I don't want to make this longer than this. All right, thanks a lot, guys.